I really appreciate the opportunity to come here to SAGES. And when I was invited by Colonel Lim, who I know he's deployed right now, and he and I have been in conversation on our LinkedIn Messenger. I jumped at the chance to come back here because I found the conversation that I had with you, to hear your thoughts, were so provocative for me and were so mind-bending. I mean, I thought this is where the value is of having these conversations, and I wanted to be able to come back to give you a little bit more information, but more importantly, to learn from you and hear what some of your thoughts are about what's happening in military medicine. I understand that we've got more than military people in our audience, and so what I've started out with is just talking a little bit about, giving people a little bit of background of what military medicine is all about. So this was the most important slide, okay? So that's me, and I don't have any conflicts of interest that I know of. Okay, so who can tell me where this is? This is the interactive part. Okay, you know it's not the OR, right? Okay, we'll start out. Anybody want to hazard a guess of what this is? I mean, it's a roll 2 somewhere, and what area of the roll 2 is this? Shock trauma, casualty receiving, right? Okay. And so where do you think this might be? Yeah, it's Iraq or Afghanistan. It's in Balad, okay? So I like showing this because who can tell whose army in that picture? No. And you can't tell who's Air Force or Navy, right? And I don't have a picture, and I'm looking for one, but my senior enlisted advisor at the DHA is Command Sergeant Major Rob Luciano, and he likes to talk about being downrange in Balad in the OR, and how when you go into the OR, you couldn't tell which service the surgeons or the scrub techs or the nurses or the anesthesiologists were, because everybody was either in scrubs or in gown, and the hat and the mask, unless they were wearing their service boots. And then you had to know what their service boots looked like to know which service they belonged to. And I think this is an important part. I think, how many of you have had a chance to be deployed? Okay. So a good number of you. And I know Captain Kelleher has been deployed many times, as I'm sure many of you have been multiply deployed. And I think this is an important aspect of what I want to share with you, and that is, in military medicine, one of the biggest and strongest and most profound lessons that I think we've learned is that we did an exceptional job in the last 15 years of war taking care of our wounded warriors. And part of our success was how well we came together and worked as a tri-service group, and more importantly, how we ended up standardizing our resuscitation protocols, our treatment, and then following our wounded warriors as they traversed from point of injury all the way back stateside and into rehabilitation. And I think those are really some very powerful enablers for how well we did. And I'll show you some of the data that we have from that time too. So at the Defense Health Agency, I thought I'd give everybody just a real quick blurb on that. We were set up in 2013, and we got to FOC in 2015. FOC is the full operating capability, and we reached that point in October of 2015. I became the second director in November of 2015. And the entire point or the purpose of the Defense Health Agency was to help Army, Air Force, and Navy medicine come together and find those efficiencies. Because when you look at how we deliver health care and how we deliver any kind of our services within the military, so much of what we do is dependent on processes that are fairly similar. And if you think about it, there are a lot of things that you can think about right off the bat, like with pharmacy, the healthcare plan, logistics, health IT, some of those things all came together in the Defense Health Agency. And when we talk about how we're going to stand up a more globally integrated healthcare system, for me what that means is how do we create the transparency not only within each of our services but across our services so that we can continue to learn from each other and then be able to achieve that more standardized, more consistent outcome approach that we want to be able to have. So that standardizing clinical and business practices really speaks to then how do we reduce that variability. And those of us that have had a significant amount of clinical work, we all know that when we can reduce the variability in our clinical practices, then we also end up with more consistent outcomes, more consistent products, And also, we can then be able to be, we're much quicker to identify where we can improve some of the things we're doing. We also oversee the TRICARE contract for our 9.4 million beneficiaries. And then in the National Capital Region, and I know that we've got some folks here in the National Capital Region, what we're doing is looking at how we can integrate our system between the direct care and the purchase care and across all the services in the National Capital Region to integrate our system of health and readiness around our patients. So that's kind of a thumbnail of what the Defense Health Agency does. Some of you know this one, and as a matter of fact, I borrowed this. Actually, I kind of lifted it from the Joint Trauma Journal, the Trauma and Acute Care. And you can see on that bottom line what our case fatality rate was in Afghanistan. And that was in spite of that top line, which was the increasing injury severity score. This is really, really compelling. So I mentioned a few things that I mentioned earlier about why I think this is so, and a lot of it has to do with our being able to standardize our behavior and how we treated our patients and being able to follow their care. But I would also submit to you one of the other things that we do in the Defense Health Agency is that we oversee the training for our medical enlisted. So within my portfolio is the Medical Education and Training Campus in San Antonio. So how many of you have heard about METC? Anybody hear about that? Okay, so what have you heard about METC? What are some of the thoughts that or what are some of the things that you know? Have any of you been there? Anybody? So what have you heard about? See, Lieutenant Colonel? Yeah, exactly. Great. And what have you heard? I'm sorry, I can't. Colonel. Yeah. Yeah, good. So you're right on target there. I mean, we do a lot of the training, the TCCC, the 68 Whiskeys do their training there. And actually, I wish we could do a little bit more cross-training with the 68 Whiskeys, with our IDC program. But my point is that our ability to get these kind of survival rates has to do with how well we're able to respond at the point of injury, right? So point of injury, being able to resuscitate somebody, stabilize them, and then get them transported to the highest level of care possible within the shortest period of time. So does that resonate with you guys there? So part of our ability to do this started with our medical enlisted, our corpsmen, our medics, and our med techs who have come through METC, where they've done their basic training, and we've standardized their basic training so that they all know how to resuscitate where in these austere environments, you know, at the point of injury. And I think that's very powerful because I think if you look at a lot of the EMS systems that we have across the United States, one of the things that we depend on is that consistency of practice and that standardization of resuscitation that allows those patients to be transported successfully to trauma centers. And that's what we ended up emulating in downrange in the combat zone. And so I think that our ability to do very aggressive standard resuscitation at the point of injury started with our medical enlisted. And in the last, for the last 5 years, well, actually, 100% of our corpsmen, medics, and med techs have come through METC. And so they're the ones that are at the point of injury and helping us start this kind of practice. So I'd also like to point out, too, some of the things that we've done here with the ACS NISQIP. And you see on there that as we participate with these quality opportunities, quality organizations that track this, you can see that we've got some within the service. We've got the Grant Medical Center at Travis Air Force Base, and we've also got Eisenhower at Fort Gordon. And so I just want to mention to Navy that, you know, where's ours? I'm just saying, you know. But I think the point is that as we participate with other quality initiatives and we look with our partners in the American College of Surgeons here in SAGES and other organizations, professional organizations, we have an opportunity not only to demonstrate the level and the level of our expertise and our achievement, but we also have the opportunity to kind of cross-pollinate and take some of those best practices from our sister organizations. And I think we need to pursue that, and which is another reason why I wanted to make sure and come to SAGES and be able to have this conversation with all of you. Okay, so here's the thing. Now, with every conflict that we've been in, we've always been able to contribute to the general understanding of care, delivery of care, especially trauma care in the civilian health system. And one of the challenges when we go between wars is that we get this dip in our competency and our capabilities because we're not doing the things that we did during the war. And, you know, as a trauma surgeon or as somebody who was forward deployed, you know that once you get into this battle rhythm of taking care of these very uniquely injured people, that you develop some pretty phenomenal skills. And so that trough that you see there is something that happens in between what we call the inter-war years. And what we're trying to do with this particular situation is how do we make sure that we don't go into that deep trough. How do we keep it relatively shallow? And that's one of the things that I want to have a conversation with you guys, because I think one of the opportunities we have here is partnering with a lot of people beyond the military, outside the military, so that we can kind of maintain that expertise that we gained over the last 15 years of war. And I think that's one of the opportunities we have here with the recent NDAA. We talked a little bit last time I was here about minimum volumes, and I know this is something that we're all looking at, and it's not even so much about are we talking about how productive we are, but I think one of the things that we also wanted to kind of wrap our heads around is how well can we show that we are proficient at doing something, and how do we measure how we get to that level of proficiency. And so there's a lot of interest in looking at minimum volumes, and here you see it in terms of the hospital, because we recognize that for as wonderful as each of our providers are, as each of our surgeons are, we're not able to do it all on our own. There's always a network of support that we need in order to take care of our patients in the way that we can get the best kind of outcomes. So here are some places, Dartmouth, Johns Hopkins, and Michigan, who have looked at what they consider the minimum volumes necessary for the hospital. And this is important because that's slightly different from some of the things that the American College of Surgeons and we in the military are looking at in terms of what about per provider, per surgeon? What are some of the kind of minimum volumes that we think or that we are projecting an individual would need in order to maintain a certain level of proficiency? So I think last time we were here, I showed this, and I think this was part of our initial conversation. And then I showed this slide, and does some of you remember this one? Okay, so these are all of our MTFs that do surgery. And what I was attempting to show here is that based on the volumes that I showed you just previously, we kind of red, amber, green, all of our MTFs to show the volumes and just kind of portrayed it like that. Now, and it wasn't done alphabetically, so don't try to sit there and try to see if you can figure out which MTF it is. And I wanted to show this not in terms of being critical, because I think the piece that's missing from this is what are our outcomes. And so Henry and I were talking about this, and I didn't get to this part because I think you're right. We need to look at the outcomes and then correlate it with the volumes to see how well they actually match up. And where we have good outcomes, even in spite of maybe they're red in volume, we ought to ask ourselves, well, how is it they're able to get those consistent outcomes, and what is it that we need to learn from that? So I love that comment, and I didn't get a chance to circle back to you. So I think that's a conversation we need to have. You know, it's not necessarily that everyone who's red shouldn't stop doing what they're doing. We ought to look at the outcomes and then see what are we doing to get the kind of outcomes, make sure that the outcomes are what we want them to be, and then figure out how we can replicate that across the enterprise. By the same token, those places that have high volumes, we need to look to see at what their outcomes are in terms of quality and value and complication rate, all of those things that we normally would do as clinicians. And then ask ourselves, how do we replicate that if their outcomes are at the level that we'd like for the rest of the enterprise? So here's what we're kind of left with, and I want to spend the rest of my time talking about this, but I'd really be interested in some of the thoughts that you might have about this. So what kind of skills do we need? And we'll start off with that. And so this is something that many of you are familiar with. We have started looking at KSAs, knowledge, skills, and abilities, and we're using the ACGME trauma model to do this. So as we're looking at what do we need to do as combat clinicians, what are some of the proficiencies we need to develop? So we've looked at it in terms of the expeditionary domains, and so there are a group of surgeons, and many of you are part of that group, and many of you interfaced with that group, who've looked at what kind of expeditionary capabilities do we need, and looked at it in terms of these particular 8 here. And then using a series of iterative processes of looking at this in a tri-service way, asking ourselves, well, what kind of capabilities and competencies would we need to see demonstrated that would show proficiency in those expeditionary domains? And I think that's a piece, too, that I would encourage all of you, if you get a chance to be a part of this conversation, then jump on it and help us understand what that could look like. So where do we need to go, or how do we maintain those skills? Well, right now, let me ask, how many of you are in an emism? Okay, how many of you know what an emism is? All right. Okay, so I'm giving you the answer here. So how many emisms do we have? 6, good, all right, so you can read my slide from where you're sitting, that's good. We have 6 emisms. Let me tell you a little bit about the emisms, or enhanced multi-service markets. So when we were standing up the DHA, we looked at where are we putting most of our resources in military health? And we came up with the 6 emisms. And what they represent is where we have the largest percentage or largest number of beneficiaries in a particular geographic region, where those patients are served and supported by at least 2 services. Okay, so one of the first, or the region that I oversee is the National Capital Region, and that is an enhanced multi-service market. So we have Walter Reed and Fort Belvoir, and then we have 9 outlying clinics that belong to the different services, 3 from Army, 3 from Air Force, 3 from Navy. And it just happened to work out that way. It wasn't really planned that there was going to be 3 of each. But the idea behind each of the emisms is that within that market, we could move our people and our resources in a way to best support the care that our patients needed, and in my mind, support the proficiency needed by our caretakers in order to be ready to go downrange at a moment's notice for readiness. And so in the National Capital Region, we have 500,000 eligible beneficiaries, of which about half of them are enrolled to the different hospitals in our market. Now, if you look at all of the multi-service markets, if you look at all of the emisms, we're looking at 45% of where the MHS puts the money, the people, patients, and equipment. So that represents a really significant slice of the overall pie. When you add San Diego and Fort Bragg, you're now looking at over 55% of where the MHS resources are going. So if we just thought about it for a little bit, if I were thinking like in terms of an investor, and I've invested the majority of my money in now these 6 or 8 markets, and I also needed to do training for our general surgeons, our anesthesiologists, our orthopods, or neurosurgeons, where would I put the training? Where would I put those people to get their training in order to get the most in my investment of these markets? You know, I'd want to put them in these emisms because they also represent where the majority of our patients are, where the majority of our cases are. And if you look at where many of these places are, like National Capital Region, Tidewater, San Antonio, Puget Sound, and even in Hawaii, there are all opportunities, too, for some of the civilian partnering that we might need to do in order to help augment some of that training. So let me stop there and just kind of see, what are some of your initial thoughts as I've been talking about the emisms? Does some of that resonate? I'm curious to see how this sounds to you guys. So, yeah, go ahead.
So when you go to like San Antonio for I forget the committee on combat surgical care, a lot of trauma leaders, ex-military, civilian, they think, to be ready to take care of trauma patients deployed, you need to be embedded in a trauma center all the time. Other people, so I'm at Camp Pendleton, they equate readiness to taking care of patients. And neither, I don't think either is realistic in the military based on our role in garrison of taking care of our beneficiaries. And to me, somewhere the answer is in between, realistically. And probably the only place that really truly does that is San Antonio because they have a trauma center there.
Yeah.
And so how do we, and maybe I'm wrong, I don't know. I guess up at UC Davis, or up at Davis, where else? Walter Reed, they don't take care of the local civilian trauma population. So how do we get there at places like San Diego or Fort Bragg and hopefully the National Defense Authorization Act will help get us there.
Yeah.
But
I think those are really great comments. I really like that. Anyone want to respond to that? Because I'm curious to see or hear how many of you are having similar thoughts.
I'm Jason Paisley from Baltimore C-Stars up at Shock Trauma. So I'm one of those trauma surgeons embedded in a civilian trauma center. And with our C-Stars program, like I'm sure all you guys know from the other services, we bring in you guys for 19 days at a time to try to give you some trauma training so when you get deployed, you're not taking care of your first soldiers. I think, like Matt said, it's somewhere in the middle.
Yeah.
That we obviously have Navy people in LA County. There's some Army people, I think, in Miami. There's the Air Force C-Stars in a couple different locations. And it's great for me. And so when I go, I know that I'm ready to go. But I think other people need to spend more time over the course of a year, or at least in the lead up, in that realm. Mm-hmm. And even when they come to shock trauma, unfortunately they join a bunch of residents. So they're there and they get to see what's going on, but they're not actually doing.
Right.
So I think it's trying, like we always talk about, trying to develop these other relationships, or even having maybe a Army team in San Antonio at the main hospital, or other places that we can just fill with that type of personnel to stay on top of it.
Mm-hmm. Good. Thank you. I appreciate that. Yeah.
Ma'am, so just coming from a minimally invasive surgeon point of view, so this readiness is, I know, a hot topic right now about how do you get surgeons ready. But what you also have to do then is you make a lot of surgeons nervous when you say, okay, are we just trying to make everyone trauma surgeons? Because in order to have a good a medical corps, you need minimally invasive surgeons, you need surgical oncologists, you need colorectal surgeons to take care of the beneficiaries and the soldiers back at home. And well, I guess I'm a little confused, and I'm not trying to disrespect the trauma surgeons, but I guess I'm a little confused in that, as you showed in the graph, we've done a very good job. And we've done a very good job with the training we had. And I can tell you, as a minimally invasive surgeon, having multiple deployments, I've never once went to the training course in Miami. I've never once went to any other trauma additional training, and done a pretty good job when we're deployed. And the graph shows that our surgeons are doing that. So I guess my question is, why is there all of a sudden a stress about, so the data says we're doing good, but then people are trying to say we need more training. So those two don't connect. So I'm confused.
How do you reconcile that?
Why that's what the talk is right now.
Okay, good. This is great. Thank you. Yes, Colonel.
Good morning, David Blake. I'm a master clinician down at Langley Air Force Base, so I'm in the Tidewater region. And I've been doing this for a little while. I was a general surgeon for a long time, went back, got the trauma ticket punched. And I think my colleagues have kind of elucidated some of the key points here. There is a balance, because we're not trying to make every general surgeon out there a trauma surgeon. But by the same token, they are all trauma surgeons when they go forward, because at the end of the day, that's who they're taking care of, is our injured service members and the local nationals that we care for, and most of them are traumatically injured. Right. So I think we need to be realistic that there is a modicum of trauma that we do and surgical critical care that we do. So there is a balance. And I think with the new push from the NDAA about partnerships, I think that is the key. And I've been an advocate of that position for over a decade. Yeah. This is not about a 19 or 30-day spin-up at C-Stars or any other trauma training platforms. Right. Those are dust off the cobwebs, make sure the lights and windshield wipers work kind of things. Make sure your team is ready to go. But at the end of the day, it's about sustainment.
Yeah.
And the only way you're going to sustain this skill set, while there are other skill sets that can contribute to that, such as the minimally invasive, the complex oncologic surgeries, et cetera, many of our folks are not doing that type of surgery because not all of our MTFs have that level of capability. If you happen to be at one of the MedCens, that's great.
Right.
I can tell you my colleagues at Portsmouth, they're not exactly rife with cases. They're struggling because every time a carrier pulls in and there's 2 surgeons on that carrier, they become part of that platform for surgery.
Mm-hmm.
So it dilutes out the experience, any experience that they are going to get. They are not a level 1 or 2 or 3 trauma center. They do not see civilian cases. And I've been there and seen the effects when one of their own gets severely injured and happens to show up at Portsmouth ER. It's a bit of a cluster sometimes because that's not what they're used to doing.
Right.
So I think there is a fine balance, and I think it's incumbent upon our senior leadership to help the local facilities engage in those local partnerships. I happen to be party to one. Most of my time is spent downtown at Norfolk General at the Level 1 Trauma Center. I still do some time over at Langley, and I help my younger colleagues, and we've got other platforms that we're working through. But getting the civilian side to understand why it's important to embed us for periods of time and help our surgeons and our other team members become proficient at this is critical. And so I think it's a balancing act, and I think all of my colleagues have really stated that quite well. There is no one single answer that's going to fit everything.
I couldn't agree more, and as a matter of fact, I had to go back to this slide here because what you didn't hear me say is I didn't say that all of these the results of this, our survivability here, what I didn't say is that everyone was a trauma surgeon who did this. Okay? We had proficiency whether you were a trauma surgeon or not. And I love these comments, and it really helps kind of frame some of the thinking, and I want to pivot off a couple of the things that you've said here. I agree, it's not a one size fits all. And I don't personally think that everyone needs to be a trauma surgeon, right? As a matter of fact, when I was one of the few trauma surgeons in the MHS, you did know when you were saying no offense to trauma surgeons that you were talking to a trauma surgeon, right? Right, Colonel? I felt at the time, and I deployed to the first Gulf War as a trauma surgeon, I felt that my greatest contribution to being in downrange was understanding how a trauma system needed to work, and then was able to structure my casualty receiving, the OR, the ICU, and the wards in such a way that we could collectively perform whatever we needed to do in order to take care of trauma patients. Does that resonate with what? Okay. So that's what I think in terms of, so how many traumatologists or how many trauma surgeons do we need? Well, I don't think that all surgeons need to be trauma surgeons. I think we need to have some of that expertise in order to understand how to design our system in order to make sure that we're ensuring the outcomes. And I do agree that there needs to be some team training, but I think we need to be realistic about what that team training looks like. Now, ideally, most of us in the OR would love to always have the same scrub tech or scrub nurse or the same anesthesiologist, but that doesn't even happen in real life. And here's an example I want to give you. How many of you have spent time with the aviators or even with the commercial pilots, okay? So, you know, the commercial pilots, they don't all fly with the same co-pilot, do they? No. But they know when they get into the cockpit with another co-pilot that they've never met, they're making certain assumptions that that co-pilot has been trained the same way the last co-pilot was trained and knows the same kind of skills or has the same kind of skills necessary so that the two of them can act as a team, right? So in my thinking, it's a little challenging for us to always have the same team trained together and then send them forward when we need them to. It is probably more realistic if we can make sure that we understand what kind of capabilities need to be acquired and what kind of proficiencies need to be supported by each member of the team and make sure that they are all trained to that same high level of performance so that when we do come together, there's minimal ramp-up time needed to kind of assemble ourselves as a team, but we all know what we're supposed to do, you know, and it's just like any trauma alert. When you go into a trauma-based situation, you know ahead of time who's got the airway, who's going to be checking for bleeding, or who's going to be ready to put in the chest tube. you know, and those tasks don't all need to be done by a trauma surgeon, but they all need to be done proficiently by a member of the team. And so that's one of the things that I think we have to have that conversation, because I agree. I don't think that the right thing to do is send everybody into and embed them in a trauma center. I think there needs to be some of that exposure, but I also think that we need to understand that there's some training that can happen outside of the trauma centers that needs to happen, and those are just basic skills. So that gets to my comment, though, about productivity and people talking about, well, is it all about numbers? Well, I don't think it's all about numbers, but we have to understand that when we're talking about productivity, are we actually talking about volume, or are we talking about proficiency? And I would submit that we actually should be talking about proficiency. But we ought to recognize that there's a range of volume that gets people to certain levels of proficiency. You know, like I would like to say, you know, I'm gonna go general surgeon on you here, and I'm gonna tell you about when I was doing this on a regular basis. I took a great deal of pride in knowing that I could take somebody's spleen out in 20 minutes. Now, I thought it was skin to skin until the OR nurse showed me that there's all this time beforehand and after that gets attributed to me as a surgeon. But there's no way I could have gotten to anything like that had I not done a significant number of splenectomies to begin with. Now, you might be that very unique person who only has to do it once and be able to perform that, you know, consistently over and over again. But I would submit that's not the most of us. I mean, so I think that when we're looking at, you know, who we should be taking care of and how many patients we should have, we should make sure that we're not sitting there thinking in terms of, oh, they're just trying to make us work more because, you know, they don't want to spend money in the managed care support contract or out in the network. Let me dispel that. You know, now that I'm the holder of the money for the managed care support contract, if you tell me I need to send patients out to the network so that you can free up your time to get more ready to go downrange, I'll pay for that. But I will tell you this, I'm going to question why people are sending out some of our patients when I know that they represent ways of being more proficient. And some of you, I don't see very many people from my residency program, unless you are one of my trainees. But we had one of our senior staff surgeons, Dr. Jordan, Captain Jordan. He always talked about the reason why it was important for us to do as many hernias as we did, which were all open at the time, was that we needed to learn how to tie knots in a hole. And he said that because you need to be able to learn how to throw and tie knots in a deep hole in a relatively safe space like the inguinal canal, so that when you got near the aorta or when you were working deep in the hepatic triangle, that you would know how to seat your knots close to where the vessel was and not develop those bad habits where you would pull the knot up and create a big hole in a vessel or in the duct. And so he always talked about, you know, it didn't matter that you were on your 500th hernia and you didn't feel like you needed to do another hernia operation. It was recognizing that the skills that you practice in a hernia operation were translatable to those other bigger cases that would eventually come your way. So, you know, as a surgeon, I really, you know, this is something that I want to impress upon you guys, that it's not about productivity in my mind. It is really about acquiring proficiency. You know, and at the same time, I think it is a given that the expectation is that we will always strive, we will always aim for that zero harm. And like Dr. Don Berwick of the IHI, formerly the IHI, likes to say, 0 is a real number. So I think that, you know, for us to say, well, zero harm is impossible, means we haven't looked at ourselves hard enough to figure out how to get there. So to some of that, I'm just trying to tie in some of the comments. Does that resonate with folks? So I think that's the conversation. And the reason I get so worked up about this is you guys represent to me the next edge of leadership. And so how many of you, I saw this from the back, but how many of you are in training? How many of your residents are interns? Okay, no pressure, but you guys need to help us fix this, okay? And I think it starts with having the type of conversation that we're having here so that we can understand there's more than one answer that's at play here. And our opportunity to continue to get these kind of results is dependent on how well we can understand what it takes us to get there and explore all the different ways that we can use in order to achieve these types of outcomes. So I really appreciate your comment about that, and that's something that really not only resonates with me, but I feel very strongly about that. I think it would be a huge mistake if every surgeon in the military were a trauma surgeon. That's not helpful. But we ought to have a good handful of them that can say, here's how we're going to set up our trauma system. And this is the kind of training, these are the KSAs that are needed. So even if you're doing minimally invasive surgery, we want you to do that really well, but we also need you to know that every now and then, show us how you're going to get into an open belly. That's not even anything that's just specific to a minimally invasive surgery. I mean, most of our surgeries are now less invasive. I mean, I don't know how many people have ever run the bowel with two hands. We're using these forceps and passing it off under the camera. But I don't know the last time that people have actually run the bowel and flipped it back and forth and milked it just to see where the perforations were. I mean, that's a skill. How many times do you need to practice that? And as we're going forward, and I'm looking at the trainees here, so no pressure. But what kind of medical modeling and simulation would help us acquire those skills? It's muscle memory at that point. How do we help you develop that muscle memory? Because we're not doing that kind of surgery in a lot of places, here in the civilian sector as well. So this is an important part, and I'm glad to hear your comments on that. I'm going to go through, I think we got to this. So anybody from San Antonio, anybody recognize this story? So this is actually, I use this as an example of one of the starting places for MilCiv partnership. So this is a San Antonio woman who was in a motor vehicle accident in which her right arm was traumatically amputated. She was brought to BAMC in order to get her reimplantation done. She was brought to a military treatment facility in order to have the reimplantation performed. And that's her with her surgeon and her therapist, her physical therapist. And it's being able to contribute and partner with our civilian colleagues. I think that is extremely important. But we also ought to recognize what we can do, what we can get from our civilian colleagues in order to help maintain, enhance, and understand where some of the leading edge changes in healthcare are coming from. This is from Baltimore Shock Trauma. We have all kinds of opportunities. I know the Air Force has, all the services have partnering opportunities. But I want us to be very careful in thinking that that's the only solution, that what we need to do is send all our teams out there. Because the other part about being in the military is stuff that you need to learn from being and working with the military. And I know each of you have some kind of appreciation, or you will sometime soon, is that, when you wear the uniform and you're wearing the rank, everybody else in the military is looking at you with a certain expectation. We wear this uniform because we're also officers. And one of the things that our line colleagues look at when they see us as a captain or a lieutenant, or as an admiral, or as a colonel or a major, is that your rank carries with it a certain level of responsibility and demeanor that they also expect you to conduct. And when I was in the accessions program for military medicine for Navy, many surgeons that we recruited would want to come in automatically as an 06. I trained at this hospital, I've done this many pancreatectomies, I've had this many peer-reviewed journals, I need to come in as an 06, I didn't ever get anybody that said I need to come in as an admiral, but I know I had probably a few that thought that. And I would explain to them, if I brought you in as an 06, there's going to be some petty officer, there's going to be some seaman recruit who's going to come to you and expect you to know something commensurate with an 06. And if you don't have that background yet, then you will end up, not giving them the right kind of direction. You will end up not being very helpful. So there's a certain amount of military that you need to acquire. It's not difficult, but you need to have that. And I think that's an important part that we have to understand. How many of you introduce yourselves as when you meet your patients for the first time? How many of you say, "Hi, I'm Dr. Smith"? Or fill in the blank. Okay. How many of you go to your patients and say, "Hi, I'm Captain or Colonel blank"? You do. Okay. All right, well, you're captain, yeah, you're captain, you're 03 captain, 06 captain over here. I don't think there's, so I noticed something about it when I was going through my training, because I said, hi, I'm Dr. Bono to my patients. I noticed that many of us will introduce ourselves to our patients as Dr. So-and-so until we get to about the rank of commander or lieutenant colonel. And then all of a sudden it becomes important for us to make 06 captain or colonel. And when we make that, now we start calling ourselves colonel or captain. If I had to do it all over again, I'd probably introduce myself to my patients as Rocky. Hi, I'm Rocky. They're going to call me that anyway. But my point is this, is that we are so imbued with our identity. Our identity when we come into the military medical departments is so imbued with being that doctor for all the right reasons. You've spent half of your adult life getting there, that's how we identify ourselves to our patients. And I don't think there's anything wrong with it, but I do ask you to remember that you're also officers. And it comes, you know, your role as an officer has a certain level of responsibility. And I think the advantage that you have being in the military is that you will learn leadership skills that your colleagues in other training programs and civilian training programs will not develop. And so I think that's an important piece. And I think for us in the medical department, and I think for the medical community writ large, I think one of the challenges is that we don't have enough trained medical leaders. And we oftentimes mistake expertise as leadership. So I offer that because I think that's really a large part of what some of our challenges need in terms of moving forward is how do we develop the right type of leadership to start addressing some of these things. So here's some example of how we're doing some of our distance at telehealth, telemedicine, and I think that there's a tremendous amount of opportunity here. But the thing that concerns me with this is that we've got people doing everything in different parts, and I don't know how well we've brought it all together. Because I think the whole idea of virtual health, telehealth, telemedicine, there's a spectrum. And because it's such a broad spectrum, we've just kind of picked off the things that we're most interested in or that are easy to do instead of trying to coordinate it across the spectrum. So what is our long-term strategy? I talk about MilCiv partnership, and I think that is an important thing, but I think we want to be very thoughtful and measured about how we do that and be very clear about what we're trying to achieve and how we're going to go about achieving it. And so many of you know that the National Academy of Sciences and Medicine has talked about what we can do to reduce, get to zero harm, reduce the trauma, recognizing there's a lot of intentional mass casualty injuries here that are occurring in the United States. And how can we integrate the lessons from the military into that civilian space, and then more importantly, sustain it moving forward. Does anyone know where this is? Boston, right. So this is an actual picture. This is from the actual event, from the Boston Marathon bombing. And I don't know if anybody had a chance to see Patriots Day, the movie that Mark Wahlberg did. Yeah. I would encourage you to see it. I mean, it was a well-done movie, but excuse me. The part that I want you to pay attention to is at the end of the movie when they actually interview one of the victims. Because I think it's very moving. It's also very profound. So the gentleman, the second from the right there, is Patrick Downs, and he's one of the ones that they interview. So he and his then fiancée, Jessica, went to the Boston Marathon to see the ending, to watch as the runners were coming across, and happened to be pretty close to ground zero. Patrick lost his left leg. And Jessica, she lost I think she also lost her left leg, and she severely injured her right leg. And so she's in the healthcare space, and so they both subsequently went through a lot of rehabilitation to regain their function. And their goal was to be able to come back to the Boston Marathon and to actually run it. This is them at Heroes of Military Medicine Awards. And Patrick is the one on the far left. Jessica, as you can see, had a completion amputation of her right lower extremity. But she had undergone dozens of surgery in Boston. They were trying to salvage her right leg when she asked if she could come to Walter Reed and be evaluated there and get treated to do some recovery. So under a program which many of you know about, it's the SecDes program. we were able to bring her on board at Walter Reed. And I'll just do an aside real quickly. Through the NDAA, we're going to have greater authority to do that type of thing, is bring in some of the civilians as SecDes designees. But one of the things that we do at Walter Reed is we pair up people with others who have had similar injuries. And so we paired up Jessica with somebody who had bilateral amputations. But what was unique about his story was, and what he did when he told Jessica, was that if I had known what I know today about how quickly it is to rehabilitate and learn how to ambulate with 2 prosthetics, I wouldn't have wasted a year trying to recover or salvage my other limb. I would have gone straight to the amputation, started rehab with a prosthetic. And it was that conversation that convinced Jessica to go ahead and have the completion amputation of her right lower extremity. And what was so upsetting to her is that at this dinner here, she wanted so badly to be able to walk on stage with both of her prosthetics. And she had picked out her outfit because she wanted to wear a dress so everyone could see her in her prosthetics, and she wanted to be able to walk across the stage with Patrick to show the impact that the military health system had on her recovery. But just before the actual event, her stump got a little irritation, so she had to take off the prosthetic. So she had to go back to using her crutches and the wheelchair. But she so badly wanted to demonstrate how profoundly that the military health system had affected her and brought her to recovery. And those kind of lessons, I think, we need to make sure are available to not only the rest of our military health enterprise, but to all of the nation. I mean, we've made tremendous progress in our resuscitation, our low-volume resuscitation, the use of freeze-dried plasma, and all of those things. We need to continue to inform that, and we've got the great opportunity here. So that is part of where I see the future going.
I've read about both of your experiences at Walter Reed. You're not from military families.
No.
You don't have military connections. What was it like being submerged in this culture with men and women who suffered like you did, but obviously from totally different kinds of sources? What kind of camaraderie developed between you guys?
So I was initially afraid that they were going to beat me up in the back of a building somewhere, because I was this, kid from Cambridge, Massachusetts, who had no military experience. I have some relatives with military experience, but I had nothing. And they have embraced us in this most incredible way, particularly Jess. Like when she rebounds from a surgery and she starts walking again, all these guys are there to pat her on the back and encourage her. And when she's really down in the dumps, they're there to commiserate with her. And they know exactly what she's going through because they've gone through it. And it's also given us a great deal of perspective because their injuries are far more severe than what we experience. Amputations at the hip, they're missing a hip. Injuries to their genitals, their rectum, their internal organs, their brains. They have been rocked in such profound ways, and we have established relationships and friendships with them that will last forever. A bunch of them are coming to town on Saturday to hand cycle the marathon, and a couple to run. And we feel like they have hosted us at the place that was meant for them. It was built for them, it's their home, and we're so excited to be able to host them at our home.
And it's things like that I have a great deal of pride in what we can do and how we contribute to healthcare writ large. And I think that when we start narrowing our focus and think about it just in terms of our scope, then we lose sight of the opportunity that we have for a much bigger, much more inclusive, and much more a diverse experience. And I think that it's incumbent upon each of us here to think about that and understand how we might want to pursue that. Very briefly, I wanted to talk about MHS Genesis just as a way to talk about how we've launched that. So MHS Genesis is our new electronic health record. It's extremely exciting. It's a commercial off the shelf. You can start helping with the deployment of this now by helping us by adopting or trying out the clinical pathways, the clinical and business work streams. Because that's a way of standardizing how we're using our existing health record, as well as, I'm sorry, I keep on moving the rollerball here. as well as our new electronic health record. We had a very successful deployment in Fairchild up in Spokane. We're going to go to Bremerton and in Oak Harbor. So, you know, Air Force stepped up to the plate, did a great job. Navy, you're up next, and then Madigan is going to be part of that initial wave. So anybody from Madigan? Okay. You know, I remember you guys too. I'm going to make sure that things go well there because we're counting on you. How well you do it there will let us compress our deployment going forward, okay? Here's the TRICARE Online patient portal, which is something that just real quickly at Fairchild, our patients found it there, and they found out that you can go online to make appointments, and the MTF wasn't quite sure, didn't realize it had been turned on, so our patients jumped all over that, started making appointments. They also found out their blue button, that they could see their actual records from their encounter that day, and a couple of the patients actually called the provider and said, hey, you know what, I actually was seeing, you know, you wrote down this on your note, but it was actually this. So, I mean, you talk about engaging patients. Now, this happens to be my TRICARE Online patient portal. And I don't know that they're trying to tell me something when they see service separation, because you asked me earlier what's going to happen after DHA. That's actually a feature that we all have, so don't freak out when you go to the TRICARE Online patient portal. You'll see service separation there. And finally, some of the other areas in terms of what I'm looking at is how can we innovate and do some rapid solution finding. And so I'm leaning as far forward as I can to work with commercial industry to find out what some of those new innovations, what those new solutions look like, and then how do I incorporate that into the military health system. The Defense Innovation Unit Experimental is DIUX. It's something that SecDef Carter set up, and what it does is allows us to work with startup companies and other established companies, but work very quickly to bring things, prototype things, and bring them on board. So there are a couple of projects that we're doing from the DHA, working with the services. We're looking primarily this time around at predictive analytics and artificial intelligence. Very exciting stuff, and I think that's definitely a part of our future. And then I should have told you this before, but really I've got some competition. It's probably just, you know, as a surgeon, it's probably just my own internal competition, but I'm trying to see how many Twitter followers I can get. So do me a solid. You know, follow me on Twitter or on Facebook. But more importantly, a lot of the things that you'll see if you do happen to follow me or the Defense Health Agency, you'll see a lot of things that we're leaning forward on and trying to have happen, and what we're trying to do in order to push the boundary on some things and ask ourselves different questions so we can have very different conversations that help us get to more feasible solutions. And I think with that, let me stop. I think I've almost used up all my time, but if there is maybe one time for question, be happy to entertain that.
So, Admiral Bono, we want to present to you this paddle, which is from our Society of Military Surgeons for your guidance and unwavering support throughout the time and for this great presentation. Thank you.
Thank you. Thank you very much.